Good evening, everyone. Welcome to our educational info webinar today on an update on COVID-19 and myeloma in Canada. My name is Gabriele Colacerdo. I'm the Manager of Education at Manager of Education and Patient Services at Myeloma Canada. And basically, I know we all wish that we didn't have to deal with a pandemic, but this is where we are, and I'm really happy to see we had quite a few people that registered for this webinar, more than we've had in quite a while for webinars, and so it shows that there's a lot of interest in this, and obviously we all want to get back to normal. So before we get started, I just want to go over a few things. I'd like to thank our sponsors first and foremost for providing us with educational grants in order to make these webinars possible. So thanks to Amgen, Binding Site, BMS, Janssen, Takeda, and Sanofi. Next, I just wanted to remind everyone that all of our webinars are recorded. So you're going to receive a lot of information. If you miss something or you want to go back and look at it again, then you can always go to our YouTube channel. So youtube.com. In the search bar, you write Myeloma Canada and you click on search. One of the first links you'll see is our channel, Myeloma Canada. Clicking on the subscribe button, I guess you become a member of our channel, and then clicking on the little bell icon here is notifications. So every time we put up a new video or a new recording from a webinar, you'll get a little notification on your device saying there's a new video available. And so that's a good way to stay up to date with all of the latest that we're providing. You can also, from our website, get to the recording. So myeloma.ca. You click on the resources button in the menu, and then you click on educational videos, and that'll bring you to our YouTube channel. Lastly, how do you ask questions? So whether you're using a tablet, a phone, or a computer, you have a button that says questions, and so this is what it looks like on a PC. Click on the questions button, and you can type in your question and press send. On your phone or on your tablet, it's pretty much the same thing. You click on the questions button, you type in your question, send it to me. I will receive the questions. I will ask Dr. Kaedbey the questions at the end of the webinar, and we'll have a discussion back and forth. Now, we got a lot of questions submitted before the webinar, and so the presentation is kind of structured in a way to answer a lot of those questions as we go through it. So and then at the end we'll have a discussion about COVID vaccination. So if you have any other questions that we didn't cover, please feel free to send them to me, and I'll be happy to ask them. So without further ado, I'd like to introduce you to Dr. Rayan Kaedbey, who is Director of the Autologous Stem Cell Program and Apheresis Unit at the Jewish General Hospital in Montreal. Dr. Kaedbey, thanks so much for taking the time at 7 o'clock on a Tuesday night after a long day of work to come here and give us a presentation.
Thank you for that introduction, Gabriele, and hi everybody. I wish that it was in different circumstances where we could be all together, but I guess this, in a way, this whole teleconferencing and telehealth has allowed for information to be diffused over larger territories. So I'm going to try and do my best to address a lot of questions and concerns pertaining to COVID-19. And my main disclosure is that it's very new, so a lot of our we don't actually know a lot of answers to the questions, the great questions that you have, but we'll do our best, and I'll do my best to try to answer your questions. So here's the outline of the talk. So what is COVID-19? I think that's probably been beaten up a little bit, but we'll do a quick overview. So COVID-19 and myeloma. So a few of us across the country, so myeloma physicians from across the country, from BC, Alberta, Ontario, and Quebec, we did get together to try and formulate a little bit of a strategy for our patients, and that's been published recently. And so a lot of what I'll be saying will be referring to that publication as well. And then finally, the famous COVID-19 vaccine. So what we know and what we hope to know, and we'll see if I can help to answer some of your questions. So COVID-19 basically stands for coronavirus and infectious disease, 19 for when it was first discovered in 2019. And so there are several different types of the human coronaviruses. And at the very beginning, when we were seeing sort of the different degrees at which some people were getting ill compared to others, there were theories about prior exposures that may have set the grounds for being a little more protected versus others who have not been exposed to some of these other types of human coronaviruses. But this one is a new coronavirus, a novel coronavirus. And in rare instances, when a coronavirus comes from an animal, so has not been confronted by us yet, it can lead to essentially what's happening right now. There have been examples of this in the past with SARS and MERS, but nothing to the extent as to what we're going through right now. So what are the common symptoms? So the most common symptoms are often respiratory and associated with fever. So, but then it just like all viral illnesses, it comes with sort of a variety of other symptoms. What we also commonly see are sort of myalgia, so diffuse sort of muscular pains, sometimes even joint pains. And then you see here as part of the list of less common symptoms, diarrhea. The headache is, I mean, it's listed as a less common symptom, but we see it quite often. And then the famous loss of taste or smell, which seems to be quite unique to this virus. And in people who have experienced this, it appears that the time for it to recover is measured more in the realm of months than in weeks. So it is something that's slow to come back. Then there's the rashes and the so-called COVID toes, which have been described more in the pediatric population. And then the more serious symptoms were leading to hospitalizations pertain to the respiratory system, difficulty breathing, shortness of breath, chest pains, and then there's what's been noted with this virus is that it could cause your blood to become thicker and lead to things such as stroke. And so these are symptoms that are often also very concerning. On average, it takes about 5 to 6 days when someone has been exposed to COVID for them to develop symptoms. And so that's why sometimes when there's been an exposure, we often say don't bother getting tested like the next day because the yield of that test is lower. And so even if you were to be asymptomatic, as you've heard many times that some patients, some people remain asymptomatic, testing at 5 to 6 days after exposure is what will likely give you the best chances of getting an accurate result. How's this transmitted? So at the very beginning, again, you saw people wearing all sorts of different masks, N95 masks, regular masks, which one should be worn. And again, it's been a learning process. It's been a year of learning. And so initially there was thoughts that maybe this was something airborne, which is why the N95 masks was worn. But what was discovered eventually is that it's very similar to a lot of other viruses, which is that it transmits mostly by droplets. And so when people cough or sneeze, it'll spread through these droplets and will essentially land on surfaces. And so that's why you can catch it by sort of touching surfaces where people who have had coronaviruses have touched. And the droplets can vary. And so depending on the size of the droplet, it'll either drop quickly to the ground or it might sort of stay sort of lingering in the air and then will sort of settle down. But for the most part, it's not something that's sort of circulating around in an airborne type fashion, which is why using regular masks is okay. And N95 masks are reserved for circumstances where you can have a lot of these small droplets or what we call aerosolization. So there are certain medical procedures that might lead to these small droplets to sort of get this diffused into the room. And so in those circumstances, N95 masks are still recommended, but on a day-to-day, regular masks are enough. In patients who are asymptomatic, it appears that they could still transmit it. So despite not having any symptoms, they could still transmit it, albeit sorry about that. Something just happened to the computer. I'm still on, right?
Yeah, you're still on. You're still on.
Okay, sorry about that. So asymptomatic patients can still transmit this, albeit it appears that it's not that it's less transmissible, but asymptomatic patients are not coughing and sneezing as much, so there's less of it sort of popping out from you. But once it is out, it is still just as transmissible. So it is still a source of transmission. Sorry, so it's the, oh, here we go. Okay, so so then how can we, what are the certain preventative measures? So again, not to belabor the points, which I'm sure you've heard ad nauseum, but washing your hands is really a thing, and it really does make a huge difference. And avoiding touching surfaces where viruses can enter quickly, especially the eyes, because there's not as much protection around that area. But essentially, you want to try to keep your hands off your face. Physical distancing, wearing a mask. If you have to cough or sneeze, try to not direct it into the air in general. And then the stuff just that you owe to your community is staying home if you're feeling unwell, and then seeking medical attention with the more severe type of symptoms. So now, what about COVID-19 and myeloma? So myeloma in and of itself is a condition affecting your immune system. Infections in general are one of the things that we worry the most about in our patients. And so it's natural to be extra concerned about this infection and you guys. So so it's not even necessarily just the treatments that often you hear us talking about how it affects your immune system, but it's the condition itself. And so even when your myeloma is stable or in remission, there is this propensity to thinking that, okay, I'm A-okay. And you certainly are better off than when the myeloma is active or on active therapy, but it's still not 100% back to normal. And there's a lot of studies that are emerging that all people living with cancer have a higher risk of infection and have higher risk of complications from infection. So, well, in myeloma in specific, where we're seeing it more and more as it becoming a chronic problem, then the same can be said about other chronic problems. So people who have things like chronic obstructive pulmonary disease, cardiovascular disorders, diabetes, these are things that are falling out as being risk factors to developing more complications from an infection. So now, there were a few smaller studies that kind of started emerging earlier on in the first wave, predominantly out of the States, out of New York, where there was a lot of cases. But now we have this large retrospective study by the International Myeloma Society. It did, basically it was represented mostly by 4 countries, however, so it was US, the UK, France, and Spain were the people who had registered the most patients onto this. However, it is kind of felt to be a little bit international, so there were other countries that contributed to this database. But it looked at 650 patients with plasma cell disorders, predominantly myeloma. So it was sort of our biggest analysis, so that we could probably take home a few messages from. And what you could see is that a good majority of patients with myeloma who contract COVID do end up needing to be hospitalized. And things that sort of fall out as being the risk factors to having kind of more complications, or basically to have an admission and have more complications from the infection are, not surprisingly, age. So the older you are, but that's sort of true to everybody. Having high risk disease by virtue of the staging. So you may have spoken to your physicians about what stage you're at, what type of myeloma you have, is it high risk or not? So people with high risk disease appear to have more complications. The presence of renal insufficiency, so if you're someone that has had their kidneys affected mostly by the myeloma, seems to put you a little bit more at risk. And then if if in the unfortunate situation where the infection comes at a time where myeloma is progressing and not in a remission state, that as well, you could imagine, was associated with more complications. What was interesting to note is that there was no association between the risk of getting complications or not and the number of prior lines of therapy, what types of therapy, and if you were on therapy at the time of having your infection. So I think so that was kind of reassuring, because we're always nervous about giving drugs to sort of, well, by suppressing the myeloma, sometimes we're suppressing the immune system. And so, but what was sort of panning out from here is that we were noticing that, okay, so perhaps it is more important to just have your myeloma in control, which would be beneficial as well. So, the subsequent bullet point speaks to what we have already spoken about. Specific drugs have not demonstrated a clear benefit against COVID. So I think you may have heard about remdesivir, which is an antiviral, an older antiviral that caught a lot of attention earlier on. But now there's been several sort of studies that are a little bit more robust that didn't really demonstrate much of a benefit. Something that I'll plug in that just kind of came up in the last few days, actually, is a study using a drug called colchicine. And it's a study that was sort of based here out of Quebec, but it did involve other countries as well. And it does appear to be promising. It isn't published yet, so I think we have to reserve major sort of decisions on it. But the nice thing about it is that colchicine is a frequent medication that's used in the treatment of gout. It also serves as an anti-inflammatory in certain cardiac conditions. It's a drug that is pretty well tolerated, not expensive. And in this study, it appears to, if you take it on, it's meant to be given before things kind of get bad. So if you're an outpatient, or if you have certain risk factors that put you at higher risk of getting hospitalized, this appears to sort of decrease that risk by about 25% or so. So I think we need to hear more about this drug. I think I'm not so sure about the inclusion criteria. It wouldn't surprise me if cancer patients were not put on this type of study. But that being said, the way I sort of see it is that it's a regimen that has very little downside in terms of side effect profile. And so I think that if I was particularly concerned, I would have a low threshold to thinking about giving it. But to be continued, I would say, until we see sort of a little bit more results from this. And essentially what happens when there's an infection to a patient with myeloma is that it's that risk-benefit balance that you often hear us talking about. It has to be individualized to the patient. It has to be individualized to the setting. So it's no secret that Quebec is often in the hot zone. And so, there are times where our hospital in specific just makes it nearly impossible and very risky to entertain certain treatments, which may not be the case in BC, for example, where rates are much lower. So a lot of decisions have to be made based on the individual risk factors. So in terms of the patient who's in front of us, as well as the sort of the societal situation at that moment as well. So just a quick overview about what happened with the first wave and what we've learned from the first wave. So I think what we've learned is that in certain patients, so myeloma is on a spectrum, as you all know, and in certain patients who have high risk myeloma, I think it became clear that this is not the population in whom you can kind of compromise, or not even compromise, but consider changing therapy if it's working well. A lot of the decisions that were made in the first wave, and which kind of come up in that publication that I had mentioned about earlier, are based on a little bit of data, albeit not big studies, but there was data supporting a lot of the decisions that we were recommending. But again, it's not, it wasn't in the magnitude that we would sort of feel comfortable doing in any other setting. So really in patients who have a more aggressive type of myeloma, we've realized that this is something that just needs to proceed. So you would need to go with your usual care, little modification. I think if there are procedures that are perhaps not as essential, those could be sort of postponed. But for the most part, it would be business as usual to mitigate the risk of the myeloma. So over here, you could see that we individualize treatment based on these factors. I mean, this is the first point, and the second point is basically at all points in time, COVID or no COVID, and the third point as well, I would say, even the fourth point. But obviously now with COVID in the mix, and understanding who would potentially be at a higher risk of complications from COVID, we now work that into the decision making as well. With the first wave, almost across the board, across the country, autologous stem cell transplantations were put on hold. And that was for a couple of reasons. One, because for those of you who have had an autologous stem cell transplant, you understand that sort of nadir, that like 10-day period where the immune system is pretty much non-existent. And so there was a big concern about risk of infection during that period of aplasia. The second concern is that although autologous stem cell transplants are now viewed as being extremely safe procedures, there is always that 1% chance of complications with the transplants, which would require more intensive type therapies. And in a situation where, for example, at the Jewish General Hospital, at some point the ICU was literally almost saturated. And so it was an uneasy feeling about putting someone through a procedure without necessarily having the support that we usually have. So because of those two reasons, autologous stem cell transplants were pretty much put on hold. Stem cell collections went on, however, because although, and again, the recommendation of holding the autologous stem cell transplant is based on, certain studies that have demonstrated that a few extra cycles of induction chemotherapy or even delaying transplant in the grand scheme of things does not affect the overall outcome. So we felt comfortable in making that decision about delaying the autologous stem cell transplant based on that kind of stuff. That being said, of course, it's not an easy thing to do from a patient perspective. It's very anxiety provoking to have something planned that is being that you're sort of revving up for that ends up being postponed. So we learned from the first wave that even though it's doable, I think in certain circumstances in this second wave, we probably will be proceeding with some transplants. And I'll get to that a little bit more. Based on the International Myeloma Society study, where it didn't really show that having had a stem cell transplant in the few months prior to infection didn't seem to have an impact on the outcome. That being said, they don't talk much about getting an infection during an actual transplant, so that's where there's still a little bit of uneasiness. However, I think it was reassuring to see that having a recent transplant at least did not necessarily lead to worse outcomes. Before I kind of came back to this point, I was going to say stem cell collections continued as is, because the concern is that with more and more therapy, stem cell collections can sometimes be a little bit compromised. So we decided to still go ahead and collect and postpone certain transplants during the first wave. In terms of the myeloma drug therapy, so certain people were switched from, so in patients who were transplant ineligible, where there was an option of sometimes going through a treatment that would involve subcutaneous injections versus just pills, more patients were sort of pushed towards the pills. with the understanding that the outcomes would probably be similar. And then certain drug therapies where bortezomib, which is the subcutaneous injection, we were able to get access to an oral proteasome inhibitor. And so even though this hasn't really been done in a lot of studies, there are small phase 2 type studies that looked at switching the bortezomib in the famous CyBor-D treatment that many of you have probably been on or seen, and replacing the bortezomib to ixazomib. These studies were done predominantly in the transplant ineligible patients. And so in certain centers, the transplant ineligible patients who were on that regimen were switched. With regards to transplant eligible patients, it's a little bit trickier. The all oral regimen that has been studied in that situation involved ixazomib, Revlimid, and Dexamethasone, which is a triplet combination which was not accessible in our country. And so a lot of patients who were on the road to transplant remained on CyBor-D. So these are just a few, I didn't want to get too technical, but these are just a few examples of how we came together to try and best choose pathways for in the safest way without compromising the myeloma response. Things like the bone protectors that many of you are probably on were spaced out a little bit more. So whereas the recommendation at the beginning is often to give it monthly for the first 2 years, it's possible that, depending on the situation, since some patients have more bony involvement than others, it was fair to sort of spread those out sooner than later. And then there's telehealth, and telehealth took the hospitals by storm, I would say. It was quite difficult in the first wave. Our infrastructure was not set up for that kind of thing. In some ways, it was for certain patients, and we've since outlined patients in whom telehealth probably would make a whole lot of sense for example, in patients on maintenance. It was reassuring to have telehealth as an option, to have bloods done kind of closer to home, and follow-ups by phone. And then if an issue was sort of flagged on the phone call, then a follow-up would be made in person based on that. So depending on each province, each hospital, the decision to go full on telehealth versus for some patients versus other was all dependent on the situation locally. So I can tell you, for example, at the Jewish General Hospital, for all patients on active treatment, we made the decision to still see the patients in person because we found it quite difficult to understand sort of side effect profiles. But this was not true to other institutions in whom the risk of transmission was higher in their hospitals. And so it's really kind of hospital based, but for the most part, what we did learn from the first wave is that telehealth is possible. It is able to be done safely in many patients. And so I think this might be a certain strategy that is here to stay in some very stable patients. So I think I may have jumped the gun, but so here's a little more about the stem cell transplantation. So we, just in general, hospitals were required to minimize all elective procedures. So I'm sure you've heard that operating rooms were also closed. So the main concern with the stem cell transplant, was the immune system being sort of at that very low although it's not a very long period of time, but long enough for us to be concerned. And then the other thing was the scarcity of the resources. And so this is where what I was mentioning about the additional cycles of induction therapy. So that is based on, the decision to do that was based on the fact that there are some studies showing that it does not affect the efficacy of the transplant. And so it says here some centers, but I would say that, again, we tried to come up with a consensus across the country. I think all centers continued with the stem cell collection. And so one little caveat is that so the way we collect stem cells is done somewhat differently at different hospitals as well. And this was something that we were doing at the Jewish, where we were using cyclophosphamide as part of our mobilization to get the stem cells out of the bone marrow. But there's a risk of having low neutrophils with that. And so we moved towards just using GCSF and then plerixafor, which is another medication that does not affect the immune system, I would say. So these are some switches that were made to mitigate the risk of collecting the stem cells as well. So again, we were trying to prioritize at some points reducing the risk of exposure, especially at the very beginning. I would say when we didn't know as much about the virus, we were very, very concerned about that. Even now, when we know a lot more about the virus, we're still concerned, but I think we have measures that are much better at dealing with the infections. But that being said, in patients in whom we feel is safe to minimize the exposure, we're still proceeding that way. And so there's few patients who are on bortezomib maintenance. The majority of patients are on lenalidomide maintenance, which is a pill form done at home. In certain patients in whom are felt to be higher risk, there's some data supporting using bortezomib, which is a every 2 week subcutaneous injection. And so in those patients, they were switched to ixazomib. Now, there's some maintenance data for ixazomib post-transplant. And so based on extrapolating from that study, we felt as though it would be safe to do this move. In that study, with regards to the high-risk patients, it was harder to sort of interpret the details. But that being said, we felt as though it's the same family of medications. There's a study showing that there's a benefit using maintenance after the transplant. And so this was felt to be safer to decrease the exposure risk in the hospitals. The second point is what I had sort of talked about in transplant ineligible patients, where already a vast majority of the patients were on lenalidomide and dexamethasone. There were some patients who were still receiving bortezomib-based therapy up front, but the decision to go between one or the other sometimes had to do with certain characteristics, whether the kidneys were more involved or not. But lenalidomide and dexamethasone is safe in almost everybody as well. So patients were more likely to be put on that combination to again minimize exposure. So we talked about ixazomib as a replacement. And so the last bullet point is what I had mentioned: ixazomib with lenalidomide and dexamethasone for transplant eligible patients. So that I think would be the ideal. But I think that's something that it's not funded in Canada, and it would have to be sort of a very, I think, unique situation in which you could access these triplets. And so in the meantime, when you cannot access that, patients were maintained with the bortezomib-based therapy. With regards to this other point here, I prefer subcutaneous to intravenous formulations. So I think that's referring to, let me see if there's some on the next page. Yeah, exactly. So the daratumumab, where now it appears that there's studies supporting its use in subcutaneous form, which basically decreases the time dramatically in the clinic. So prior to having this formulation, though, there was a protocol to speed up the infusion. So at the very sort of onset of daratumumab, the infusion, as you kind of had your first few, was sort of bubbled down to almost like 4 hours. And since then, there's been this rapid infusion protocol that we had through the Myeloma Canada network to sort of get this up and going, which demonstrated the safety of administering it much faster, over 90 minutes after the first 2 infusions, and ensuring that there were no reactions. So again, this was with the first wave. I think this won't really happen with the second wave, where there was at times concerns because daratumumab, one of the side effects is in fact infections and pulmonary infections. So there was a particular concern with regards to COVID. But now with this International Myeloma Society study, where it didn't really pan out as being a risk factor, and knowing that daratumumab is a drug that really has sort of made the biggest splash, I would say, most recently, that there was considerations of spreading out the doses. But I think with this subsequent wave, daratumumab will be given as it should be. I think in centers who can access the subcutaneous formulation, that should probably be the way to go. But for now, until sort of funding comes for it, the 90-minute infusion is a very fair thing to do. The other kind of very stressful thing was clinical trials that were put on hold. So this is obviously something very distressing for certain patients. It's almost the only thing that would potentially help. I think with the second wave, we're going to be trying to protect that as much as possible, but it is still a very big reality because a lot of the reasoning behind why therapies were trying to be moved to more of an outpatient basis is not only necessarily because, as much as we would love this to be the primary reason, which is to mitigate your risk factor for yourself, but it's also because the unfortunate reality is that our resources in the hospitals were really spread thin. So our oncology nurses, who have basically a very special training in order to be able to give all these drugs that they do, were being repatriated to COVID units, which obviously led to our inability to give treatment as well. So part of the reason with having these other strategies was also because, well, we needed to think of a way to give something rather than nothing. So with those two things in mind, that was a lot of the reason why certain of these decisions were made. And so it's the same thing with clinical trials. So although clinical trials sometimes are these big studies that are international, a lot of the work is done locally. And so again, from a pharmacy standpoint, from a nursing standpoint, resources become a real issue. And so that is the reason mostly why we were having an issue with having ongoing enrollment. But hopefully with the second wave, things are a little bit more organized, and that won't be as much of an issue. So again, so supportive care we spoke about. So what we mean by supportive care is predominantly the bone strengtheners that are usually given monthly for the first 2 years after the diagnosis, and then spread up to every 3 months. I think that in patients who don't have as much bony involvement, and in people who are responding to their treatment, it is fair to say that these drugs can be spread out to every 3 months earlier. Again, with more experience, with more knowledge, with more understanding of these therapies, we know that in fact that these medications don't leave your system very quickly, and that although the studies were designed on an every monthly basis, probably these drugs are still inside of your bones for longer than that. And so I think it was very fair to, again, have this be one of the exposure risk mitigation strategies. Bolstering the immune system. So some of you may already be on what we call immunoglobulin replacement therapy. This is given in two ways. It's either given intravenously, often once a month, or some people can get it subcutaneously, where they self-administer it 1 to 2 times per week, depending on the dose. And this is historically, this is given to patients in whom they have recurrent infections based on the fact that their immunoglobulins are low. So some myelomas have a tendency of lowering all your immunoglobulins. And so in patients who have these very low immunoglobulins, who have had a lot of infections, giving this replacement decreases that risk. And so this is another thing that in patients who are sort of not on this, but maybe could benefit from it, it's something to think about as well. So growth factor support. So some of you may have already seen these medications, which are called GCSF or Grastafil, used to be called Neupogen. So these are medications to boost white cells. And so certain therapies will lead to lowering your white cells, and sometimes it's not too bad and it's tolerable. Other times it's a little bit too much, and so you would need to be on these medications to boost up your white cells. And so now it's possible, like, during this time where you may have a higher risk of exposure. Again, there's no real data supporting this, but if there's that concern that potential COVID infection is high, then if you're someone who has low neutrophils, this might be something to look at as well. So the telemedicine, so we basically more and more follow-ups are being done through telemedicine in patients who have stable myeloma or those on maintenance therapy. I find that it's particularly good for my patients on maintenance therapy. I think they're happier this way, to be honest. And I feel okay about it just based on the fact that some of these patients have been on maintenance for years now, and I have had the history of the last few years of seeing how well they're doing. And so I think it's fair to sort of have these done over the phone. Patients with long distances to travel for appointments, I think, well, that's like a point, again, that I feel is there. The long distances are there with or without COVID. And so I think with our experience and seeing how successful that it's been in certain patient populations, that perhaps, an in-person visit can occur less frequently, and then some phone calls in between. I think we've gained confidence in doing that through these telephone calls. So it's convenient. It does reduce stress for two reasons: one, getting to the institution; two, that concern of exposure in hospitals. And what it also does is it does free up the waiting rooms for those patients who definitely do need to be seen for whatever reason. So it frees up the blood taking rooms. It frees up the clinic waiting room area. The wait times for in-person visits tend to be shorter. So in a way, it's also serving the bigger picture as well. In some patients who have been on treatment for a long time as well and have been very stable, so whether it's in maintenance patients or even in patients who are just on ongoing therapy at the time of relapse, for example, where historically bloods are asked for almost before every dose. But if you have that historic of looking back over time and noticing that, well, okay, they've been doing these bloods every week, for example, to just be sure that it's okay for the chemo and that everything is fine. But in these last, almost year or so, nothing's ever really been done about it. Well, I would feel comfortable with that person doing less blood work. So again, decreasing exposure. And then getting bloods done locally, faxed to us. Although, albeit that there is subject to availability, there's been a huge demand now on sort of home blood tests and all that stuff. So, but I think it's a practical way of getting these tests done. So what are we doing now during the second wave? So based on what I mentioned about the IMS study, where having a recent transplant did not appear to lead to worse outcomes with an infection. So with the caveat that there's not much in the way of getting an infection during a transplant. So I think that we still need to proceed with caution. But I think in patients in whom we feel uncomfortable about delaying a transplant, and again, that's often not the majority of patients, tends to be more the higher risk patients or harder to treat patients. So in patients like that, I would feel more comfortable just proceeding through with transplant and not delaying it based on our first wave experience and with what we've seen with some of these studies. I think the bone strengthener to every 3 months is here we'll continue that through the second wave. I think we haven't seen any downside in doing that. Telemedicine will continue through the second wave. I think would have more confidence in it now, actually. So we were all kind of reluctant with the first wave and had a lower threshold to bring people in. I think we've noticed that, in fact, it does work for certain patients, and so that will continue. And who knows, maybe continue even beyond that. So the concern, as you can see over here, is that there's always that concern that you might miss a symptom. I mean, a lot goes without saying with regards to body language. So to hear someone say, "I feel tired" over the phone versus to see someone say, "I feel tired," and you're seeing the person, it has like a completely different feeling for us as physicians. And so that's why we might belabor the point a little bit more on the phone, but it is something that's difficult, but we are sort of getting more experience with that. And I think our infrastructures are also getting more experience with that. And so things that we were more concerned about with the first wave about falling through the cracks and who's going to call back who with regards to setting up follow-ups, those are sort of being ironed out as well. So the limitations, again, to telemedicine, if someone tells you, "I got a rash," well, I mean, we're trying to put into place video calls as well, but nothing ever replaces that sort of, I see that rash with my own eyes. So I think we'll be trying to help with different strategies, but in the end, if there's a feeling to have to be seen in person, well, we'll make time and ensure that can be done safely. So let me just, oh my gosh, we're kind of running out of time. And I think this is a hot topic. And I know that a lot of the questions address this, but I didn't leave too much time because I think this is these are the questions that we don't actually have a whole lot of answers for. I think I'll try to answer the questions based on what makes sort of scientific sense, understanding that there's very little data. So with regards to its safety, I think with regards to the two approved vaccines right now, so the one created by Pfizer and the one created by Moderna, so this is sort of a newer technology. It uses something called messenger RNA or mRNA to basically tell your body, produce this protein called the spike protein, which is found on coronavirus, and recognize it so that when the real spike protein comes in, which is the protein that allows the coronavirus to enter our cells, get rid of it. So there's no safety concern from a standpoint of getting infected by this particular vaccine, by these two particular vaccines. There's a lot of vaccines in the pipelines. Up until now, I haven't necessarily seen any live vaccines or attenuated vaccines. I think the ones I've heard about are either protein vaccines or dead viruses. But that being said, as you might hear of newer vaccines, one thing that we always ask first is this a live vaccine? Is this an attenuated live vaccines? These are things that I would say I would not feel comfortable about giving to my myeloma patients. So I would say in general, the approved vaccines are safe from a safety perspective. I think the concern is more the second bullet point, which is the efficacy. So, and this goes across the board with all vaccines. And you may have heard us give you this spiel before, but essentially, it's hard to extrapolate the efficacy results, which were done in patients who have normal immune systems, to patients who have myeloma or other conditions that affect the immune system. The feeling is that you will get some protection from it. Will it be that 95% protection after 2 doses that we've seen in the studies? That's unclear. And that's why we often say, when we're vaccinating for all other things, including the flu every year, we say, well, those members in your household should probably be vaccinated as well, because the safest thing for you would be to not have it come to you. So you can get vaccinated and see what kind of efficacy we get out of it, but more importantly, those around you should probably be vaccinated again. So I think the rollout of the vaccine is not super clear. So here's sort of these prioritization rules. There's federal and provincial governments are constantly updating their strategies. To be honest, I cannot even tell you what the strategy is right now. I think it may have changed already. But what I often tell my patients is that we're kind of always surveilling it with regards to our patients and what the recommendations will be. We all want it for our patients, and so I think once that information is going to come out sort of publicly, we'll be diffusing it as well as quickly as possible. So here are just an example. You can get these off the Health Canada and your provincial health websites. But essentially, right now, the vaccines are being prioritized for long-term care facilities, older patients, and healthcare workers. And I think eventually it's going to sort of pan out to other essential workers, and then eventually get to the general public. So these are some links to the public health websites. So I'll get to the discussion points. So, yeah.
Kaedbey, I mean, since we're at the discussion, maybe I can just come in and I can just basically just go through each point with you, if, or you could do it on your own. It's up to you.
Oh, I don't mind.
Since we're at the end,
these are just kind of points. So if they're coming from questions, if you want to sort of ask the question around the point, that's fine too.
Yeah. So I guess let's do that. That way people are they know that we've addressed their question. So basically, the first question, chemotherapy and myeloma therapy, is, you know, if someone is on chemotherapy or on myeloma therapy, what's the, you know, what's the indication for vaccination, and when would it be safe to have a vaccination?
So again, excellent question. And I think, you know, what we'll probably be able to do is mostly extrapolate from what we know about with other vaccines. I think that generally speaking, so the biggest amount of vaccinations that we recommend often are post-transplant. So in those who have had transplants, we give sort of this list of vaccinations to be done 3 to 6 months after the transplant. And a lot of times patients are on Revlimid maintenance already, for example, and it's been shown that on the Revlimid maintenance, it's safe to do so with these vaccines, with the caveat again that these vaccines are all non-live vaccines. So I think it's hard to answer this question, because I think that obviously our drugs are targeting plasma cells, which are there to make antibodies. So in targeting the myeloma cells, we're also targeting the good B cells or plasma cells that will form. So it's hard to know, but I think that at this point, we don't have much of a choice. I think interrupting myeloma therapy to give a vaccine also, I don't know how comfortable I would feel with that kind of a plan. And we did talk about it recently on a group call with Myeloma Canada. And I think at this point, we're almost going to have to take what we get. So once it becomes available, I think we'll just have to kind of go through the vaccines, and whether or not we end up discovering that certain people will need a booster shot or a follow-up shot based on what treatments they've had, I think that's going to be the path that we go for.
Okay, so basically, let me just jump to the third bullet point, since we talked about the transplant and the maintenance. So we know that, you know, maintenance therapy, it's usually 21 days on, 7 days off. So would it be plausible to think that during that 7 days off would be the moment to get the vaccine versus during the 21 days where you're on the treatment?
So I don't think it would matter, to be honest. I mean, to create an immune response takes weeks. So to think that giving it during that 1 week off will make much more of a difference, I don't think it would have a big impact. There are some patients also who don't get a week off of maintenance. So maintenance is given sometimes 28 out of 28 days. And what we are seeing, though, is that in patients who are on maintenance and getting vaccines, they're still mounting a response with regards to other vaccines. And so I would say that perhaps it's fine to get it in your week off, because generally you're a little bit more peppy in your week off, and if you are going to have some side effects to the vaccine. But yeah, I think in terms of its efficacy, it won't make much of a difference.
Okay, thank you. And with regards to the autologous stem cell transplant, you might have mentioned this, but in general, the vaccination happens how many months after the transplant? Or
So no earlier than 3 months. So I would say that you would start, so for something as like urgent as COVID, I think you could start it at 3 months. But generally speaking, the whole vaccine protocol that comes after a transplant, it sort of starts even up to 6 months. But you have to, we have to understand that even with our current vaccination profile, it's also not based on a whole lot of information. We just, vaccines are pretty harmless things, and so we base our fact that it's not a risky procedure to do to prevent potentially big infections. So we go ahead and we sort of vaccinate based on that, understanding that a transplant will certainly have dulled your ability to respond to certain infections. That being said, there was some studies that were very, very recent within the year that showed that perhaps the ultimate timing of vaccines should be just before a transplant, allow your immune system to sort of create these antibodies, go through your transplant, and then kind of give some boosters. So I think it's a field that we're learning about still. But I would say that the standard right now would be that after a transplant, no earlier than 3 months to start getting vaccines.
Awesome, thank you. So from the perspective of household members, perspective of a myeloma specialist, is that something that's recommended with other vaccines? Is it likely to be recommended with these vaccines?
I would say yes, for sure. I often tell my patients, get the flu shot, but more importantly, let your partner or your children or whoever's in close contact with you get their flu shot. And if I had free reign on prioritization, I would say my myeloma patients and their families, So I think, again, mostly harping to the fact that, okay, fine, you will have the vaccine. It's going to be safe for you to have the vaccine. How well will the vaccine work for you, though? So what the safer thing would be to prevent it from coming to you. So have the people around you vaccinated.
Awesome. Thank you for that. So we're at 8 o'clock. Do you have an extra 5 minutes or?
Sure, no problem.
Okay, awesome. So I guess the next one, if we go in order, is we already touched on it a little bit. So we don't know what the efficacy or duration of efficacy of the vaccine would be in someone with myeloma. But is there maybe a way? I'm seeing a lot of questions come in about doing some blood tests, some titering to see if there's an immunity there, and perhaps in the future. If we're able to do that and we see that the myeloma patients don't have immunity, that they get a booster. You mentioned a booster shot, an extra dose. Is that something that could be a possibility?
I think that's something that definitely will be looked at. So titers against the infection is something that's been done. The question is, so we don't know exactly how much, like it's, so myeloma or no myeloma, testing for titers, it's difficult to understand your degree of protection based on the different levels still at this point. So how high does your titer need to be, for example, for you to be protected? The other thing is how long, even with normal immune systems, how long do we see that titer last for before, and I think the feeling is that this, and again, this is complete speculation, and maybe in a year from now we'll laugh at what I'm saying, but I think the feeling is that there will have to be repeated vaccines for this, just like the flu, in order to not only kind of keep up with certain titers, but to address different variants. So I think that might come up as a question as well. But there's now these different variants that are coming about. Do these vaccines protect against that variant? So again, my disclosure that I should have also said at the very beginning is that I'm not an infectious disease doctor. I'm a myeloma doctor. And a lot of these we try to learn from our infectious disease colleagues, and you could probably learn more about from different conferences given by them. But my understanding is that the vaccine should be able to cover for certain variants, because the spike protein, I think, is common to coronaviruses in general. Those are I mean, the reason why it's called coronavirus is because it looks like it's wearing a crown with all these things, and corona is Latin for crown. So I think those proteins are almost common to a lot of different variants. So I think a vaccine will protect against some, but I don't know if it'll protect against all of them.
And I did some reading on this as well, and I saw that regarding the titers that you mentioned, even though the titers are down, it doesn't necessarily mean that you're not immune, right? So that's another reason for the unknown, right?
That's right. That's right. And we see that with other types of antibody titers in other conditions, where sometimes the levels are almost undetectable, and then they re-encounter that antigen, and then they just become detectable again. So there's something about the B cells that are still there, even though they might be at very low levels.
Awesome, thank you. The next two bullet points have a little bit to do with some of the stuff that we've been hearing in the news, and with governments trying to play around with the interval between the doses, trying to vaccinate as many people as possible with the first dose and delaying the second dose. And then just recently, I believe it was yesterday, there was a report out of Quebec where someone in a long-term care home got accidentally given the second dose, but of the different manufacturers. So they got, let's say, the Pfizer one first, and then got the Moderna one first, or vice versa. I don't remember exactly. So I know this is two questions, but the second question, from the scientific perspective, is there any safety concern if this would accidentally happen to someone?
So with regards to getting two different vaccines, so I would first say that shouldn't be the standard for sure. It seems like it was an accident. I didn't hear about it until you told me. So I would say that I don't think there would be much concern from a safety perspective. But again, I think it comes down to the efficacy component of it. So it's two different products, was not studied to be together. Perhaps that you can still get a good response, but can't be sure. So I would recommend against something like that. The time interval is an interesting question, and I don't envy the people who are in these positions having to make these decisions, because these are difficult decisions to make. I think there's a little bit of background with delaying the second vaccine somewhat in the studies. So in some of the studies, there was delays in the vaccine for X, Y, and Z reasons, and in those patients, it appears that the outcomes were still okay. So I think there's wiggle room, and I think that when they look at a little bit of longer term follow-up in patients who have had only one vaccine, the rate of protection is a little bit higher than what's reported in the studies. So, but again, you'll hear the companies not recommend this. I think the companies are bound by their trial to legally say that it has to be given this way. I think medically there is some wiggle room, and I think there's biologic backing to that. The question is how much wiggle room. So I think most provinces are delaying it by an additional 3 weeks based on the fact that in the studies, I think some patients had delays up to that long. Some other provinces, including Quebec, appear to be delaying it up to 3 months, which is, I don't know. It seems a bit more to me, but again, you have to weigh that decision against sort of the rapid fire that's happening in front of your face. So again, that's why I don't envy the people having to make these decisions, and presumably they're based on data that they have access to. But it is concerning. I would share that concern with my patients, but hopefully that the delay won't be beyond several weeks.
Yeah, I definitely agree. That would not want to be those people. No matter what decision you make, someone's going to question it, right? Either way. So, time will tell, I think, is the answer to a lot of these questions.
Exactly.
The last point that I just wanted to go over with, we've had some patients and caregiver contact us and saying, they've met with their GP or with another doctor who perhaps is not as much in the know or hasn't kept up exactly with exactly what's going on. So and they're told, oh well, you're immunocompromised, you can't have it. And because the guidelines change so fast, it's very easy for them to be able to miss something like that. And so what would you say to myeloma patients and caregivers who have been straight up told by someone who is not their myeloma specialist, or that they can't have the vaccine?
Sure. So I think this is, I'm hoping that with time, this will be less and less common, because as a community, we're trying to diffuse guidelines and our information as much as possible to the community physicians, to hematologists in the community as well, who don't just do myeloma, for example. But it is still something. And I think I may have given a little Myeloma Canada 2-minute spiel on this a couple of years back at one of the ASH. But what I tell my patients, or what I would tell you, is, don't be shy to tell, whether it's your hematologist who's in a community center who treats everything and a little bit of myeloma, or whether it's your GP. Sometimes we're worried that we're going to rub them the wrong way or offend them, but I could tell you from experience is that these people are open their arms to support from either a second opinion from a myeloma specialist, or and so you could always sort of say, can I have an opinion from a myeloma specialist, and that way. But when it comes to the vaccine itself, as a question, sort of what you're mentioning, Gabriele, I guess a little less, but just in general from a myeloma perspective, if there's something that you feel you're not having answered properly, either through Myeloma Canada, because I've had referrals come my way through Myeloma Canada saying that, so-and-so is a patient who kind of needs a little bit more support, or through your healthcare provider directly. But I could tell you notoriously, when when we're giving feedback, and I would feel the same if I was encountering a condition that I felt less comfortable with, I would welcome the feedback from someone who has more of a niche in that. And that's been the feedback that I've had when I write letters back to either community hematologists or to family doctors. It's very well received.
Great, that's it's good to know, and it's I'm happy that it's something that we try to tell as many patients as possible. You need to self-advocate. You need to be able to speak up for yourself and get the care you deserve, basically, right? So we had one small question that came in. We won't be able to get to all the questions, but I think this one we could answer really, really quickly just before I let you go. And so it has to do with the upcoming vaccines. There's one of them, Johnson & Johnson vaccine. I'm not sure if you know off the top of your head if this is one of those dead or alive vaccines. So basically the question is, will it be safe? And so do you know if it's a dead or an alive vaccine?
I think I don't know enough about it, to be honest. From what I've read and some of the preliminary stuff is that it's a one-time vaccine, which is, I think, very attractive. And it's not an mRNA technology, but I from my understanding, it's not a live vaccine, so I think it would be safe. But I'll reserve other opinions on it until I see more about it.
Absolutely, yes. When it's Health Canada approved, we can talk about it a little bit more. Yeah. So with that, like I mentioned, we had a few more questions. If you have more questions, please email me. I'll try to send you back an answer to those questions. I think we pretty much covered a lot and a whole lot of. The one thing we didn't cover was variants. I know there's a lot of questions around that, and do we want to just give like a 30-second spiel on variants before we go?
A whole lot of questions and not a whole lot of answers, unfortunately. So again, when touching upon them, it appears that for the most part, as the variants are evolving, is that they're actually more transmissible. But up until now, thankfully, none of them have appeared to be more deadly. And I was listening to Dr. Fauci speak. Actually, he spoke to us at the last American Society of Hematology, and I thought what he said was, I mean, he's the ultimate expert, I would say. And what he said sort of about the natural history of viruses in general is that, they prefer to not be as deadly, actually. So viruses in general live through their hosts. So, and when their host dies, they die as well. So the goal of a virus is almost to become more easily, like, to be spread, but less dangerous. And he gave a few examples of sort of the common cold type viruses that back in the day, in the early 1900s and whatnot, sort of initiated as pandemics, and then eventually just kind of become like the common cold. So I think the hope with these variants are that they become less, I guess, less dangerous, perhaps more transmissible, but less dangerous. But again, a lot of it is speculation, and I think we'll have to wait and see.
Awesome. And with that, I won't take any more of your time. Thanks again for doing this for us tonight. It was a great presentation. Thought it was getting a lot of good comments, nice feedback from it. So that's awesome. And as I want to, you know, sorry.
I said thank you. I appreciate that. Thank you for having me.
No problem at all. So so with that, we'll end the webinar. Have yourself a great night, Dr. Kaedbey, and for the people who didn't have their questions answered, please do email me. My contact information is on our website. I've also emailed you a few times for this webinar, so you have my email address. So thanks a lot, Dr. Kaedbey. Have a great night and take care.
Everybody.
Bye. And